Hello, everyone. Welcome. Whilst we wait a few minutes for people to join us, please feel free to pop your name and where you're joining us from today in the chat function on Zoom. All right. I think we can get started then. Good morning, good afternoon, everyone, wherever you might be joining us from. Welcome to this London Global Cancer Week webinar, Breaking Barriers, Strengthening Early Childhood Cancer Diagnosis in Ghana and South Africa. This webinar has been brought to you by World Child Cancer and CHOC Childhood Cancer Foundation South Africa. My name's Luke Kappa. I am the Program Manager for World Child Cancer's Ghana program. And today we're here to shine a light on the work being done in South Africa and Ghana to improve the early diagnosis of childhood cancer. We'll be discussing several topics from two key speakers in the field of delivering early warning signs campaigns in sub-Saharan Africa. And this session isn't just about sharing knowledge, it's about celebrating collaboration, innovation, and commitment to improving health outcomes of children with cancer. Thank you again to everyone that's able to join us today. We're thrilled to have you as we explore this together. And I'm now going to introduce you all to our key speakers for today's session. We're honoured to have with us a leader and advocate in the field of childhood cancer, Adri Luddick, the Awareness and Advocacy Manager for CHOC South Africa. Adri's journey in childhood cancer advocacy began in 1997, and over the past 2.5 decades, she's worn many hats, from dedicated volunteer to regional manager, program development manager, and serving as CHOC's national interim leader. Beyond her work with CHOC, Adri plays a pivotal role on several platforms. She serves on the Committee of Cancer Alliance of South Africa, contributes to the Childhood Cancer International African Regional Committee, and is an active member of both CCI Global Survivors Network and the CCI Global Advocacy Group. It's also a pleasure to introduce you all to Mr. Ayere Adongo, a seasoned public health expert with over 20 years of experience. He is currently serving as the Sub-Saharan Africa Regional Coordinator for World Child Cancer. Ayere has worked in many roles in his lifetime, including Ghana Health Service, WHO, UNICEF, and consultancies with USAID, JHPAGO, and ALMA. He's also an avid researcher contributing to national studies on perinatal deaths and children's palliative care. Please join me in welcoming both our guest speakers today, and thank you for joining us, Ayere and Adri.
Thank you very much.
Awesome. So we're just going to get started with some presentations from both our guest speakers. We're going to again move on to a discussion, and then this will be followed by a Q&A with the audience. We encourage you to join in on the discussion. So if you have any questions, please pop these into the Q&A function on Zoom. And okay, I think we can get started with the presentations. Adri, would you like to begin?
Thank you. Can you see my presentation?
Yes, we can see it.
Okay. So, thank you very much for the kind introduction, Luke, and thank you for the great opportunity to be part of the London Global Cancer Week, and especially the session hosted by World Child Cancer. So, CHOC's mission is to supporting children and teens with cancer or life-threatening blood disorders and their families, improve early detection, and then, of course, promote adherence to treatment. And all of this also is so the well-being of the children are good. In South Africa, we diagnose around 1,000 children every year, and CHOC impacts on around 5,000 beneficiaries annually. As you all know, a child can stay in hospital or be on treatment for everything up to 3 years, and that require frequent and regular visits to hospitals that sometimes can be very long periods. CHOC advocates for children and teenagers We believe that every child should have access to specialized treatment and supportive care. We believe that their cancer journey during the treatment should be made easier. And that is why we also have our comprehensive care and support programs so that we sort of help so that there's less abandonment of treatment. We believe that every child's human rights should always be respected during and after treatment. And then we believe that our voices, our survivors, also do have a voice and needs to be cared for. So in 2011, CHOC started our awareness training and education program, where and that our program was endorsed by the National Department of Health. And this program was developed in accordance to the World Health Organization guidelines and international best practices for health promotion and stigma debunking. In the 2015 World Assembly, it was noted that childhood cancer do not receive enough attention and that it was neglected. And we all know that the response to that concern was the Global Initiative for Childhood Cancer that was then a response to this question. And it's about a 30%, 60% survival rate of children by 2030. So our program is based on a research that was done by Dr. Stelios Piadis that he did on the Silouan early warning signs of childhood cancer in rural South Africa. The indication of the findings indicated that there needs, when you do an awareness campaign, there needs to be a longer and more formal education period to improve earlier stages of the disease and to improve referrals. The fall off of the new patients over a period dictates that the awareness campaign you need to follow up on your awareness and it needs to be ongoing. And then failure to improve earlier stages might be to the time that you spend on the program. So for that, we then decided to develop 4 strategies. The one thing that is very clear is you cannot do a mass marketing and advertising campaign if your nurses and your at the primary healthcare clinic do not know the early warning signs of childhood cancer, how and where to refer possible cases to. So our first point of entry was that we need to train the healthcare professionals, the nurses. Then we need to go to the next target audience, which is the home-based care workers, your community workers, and your traditional health practitioners, to train them on the early warning signs of childhood cancer. Only then can you start with community outreach events to distribute educational material in targeted audiences to address the misconceptions of cancer, share survival stories and awareness campaigns. And then at the end, you can go and you can highlight the issues that contribute to the lack of good treatment outcomes to advocate for our families. Now, I'm not going to go into this. I would rather take our time to share some valuable information and have a conversation, but we have reached quite a huge number of people in the past few years. But I think the best target audience is our nurses, and we've trained over 20,000 of them, also our traditional health practitioners. So the aim is, of course, to reduce the mortality and morbidity of children with cancer, but most importantly, that no child is left behind, and especially not in pain. So if you give knowledge to people, you give them resources, you give them information, the correct information, and then you hope that they will change their attitudes towards the disease. If they change their attitudes, they change their practices, and that will then all lead to early detection and referral. So we work with targeted audiences. We adapted our toolkits to these audiences. We use different facilitation, and we'll talk about that in the conversation. We use different facilitation. We use adult facilitation, and we use different methodologies to make sure that people understand the knowledge and that they can use the knowledge. And then, of course, we updated our training and marketing material to stay on par with new trends and developments, and also to stay on par with new advertising mediums. For example, we're busy to translate our early warning signs into the South African Sign Language. We use a WhatsApp bot in all the different languages for our early warning signs. And we also have we did the addendum to the IMCI manual for childhood cancer. We'll also talk about that a bit later. To break barriers between people, you can only do that if you can relate to the people. So we use, as you can see here, we use different methodologies to give knowledge. We do role play, we do group discussions, we do gamifications, we work under a tree, we work in a classroom, and we try to listen to people and to hear how they took in the knowledge that we shared with them. And then lastly, I love the saying, united for hope, health, and better futures. In 2013, we had an open discussion, an open debate between Western and traditional medicine. And over 500 people attended this debate. The problem was it was a lot of people, and the audience sat under the stage in the hall, and they had to listen to a debate. So they didn't have a voice, or they were not heard. Last Friday, we had another day like that. This time, there were less people. It was very targeted. It was very well planned. We had focus group discussions. And this time, the audience, their voices were heard. So to break the barriers and to improve early diagnosis, we need to listen to lived experiences. We need to listen to the voices of communities, and in a language that people can understand, but most of all, and I thought in South Africa, I understood cultural and traditional differences in a way. But if you do not really understand it and handle it respectfully, you will never bridge that gap that we need to bridge. So this is just a little small introduction, and now I'm very happy to give over to Ahiri to tell us about Ghana. Let me just stop sharing. There you go. Thank you.
Yeah, thank you very much. And I will take over from where Dre left. Basically, we have similar strategies in trying to improve on awareness creation. And I think it's common knowledge that globally over 70% of cancer-related deaths will occur in lower and middle income countries. And the most common types of childhood cancers are leukemias, the brain cancers, the lymphomas, and then the solid tumors. And there is some disparities in terms of the incidence and mortalities in high income countries and lower and middle income countries like Ghana, and where we have about close to 80% of the mortalities taking place in lower and middle income countries, as compared to close to 90% survival rate in high income countries. And these inequities are very, very unfair. And where we have reached globally, COVID taught us that we all have to be concerned. And in lower and middle income countries, there is a high incidence of misdiagnosis because of poor health systems. And these situations are forcing families to abandon treatment most usually due to high cost of treatment and the fact that health professionals lack specialized training. So there's a double burden here where we have very poor health outcomes due to poor health systems coupled with poverty. And this situation is really very, very bad. And regrettably, childhood cancers are generally not preventable or identified through screening, except for retinoblastoma, the eye cancers, which usually can be screened, but the rest are generally not preventable or even screenable. And that places lower middle income countries in a precarious situation. Ghana has made significant strides in healthcare, especially on early and accurate diagnosis of childhood cancers. But still, there is a critical challenge. Ghana has been able to improve on the survival rate, but still, there are still challenges due to socioeconomic factors, and about 1,500 children are expected to be diagnosed annually in Ghana. But because of the factors I mentioned earlier, the poor health systems, the social-cultural factors, the myths surrounding childhood cancers, most of these cases are not usually picked up. And we only have about 1/3 of this 1,500 being picked up and diagnosed. And even with that, there is late presentation, which still gives the country a lot of challenges in ensuring that most of these children survive. So the one of the best strategies that we intend to employ to tackle some of these problems is the early diagnosis, awareness creation, to ensure that we are able to improve on the situation of late presentation so that people can come early and so that they'll be able to pick them up. I've mentioned some of these challenges to early diagnosis in Ghana, the lack of public, and then even some of the health professionals are not very aware of the early warning signs and symptoms. When we did monitoring to most of the health facilities, some of the seasoned medical professionals, doctors and nurses that you would have expected to know some of these were unaware, and that makes it even more serious. And then we do not also have adequate treatment centers. In Ghana has currently 4 major treatment centers and a host of shared care centers dotted across the country. And even with this, it is still not adequate. We need all the health facilities, especially those at the primary healthcare, to be well oriented so that they will be able to refer for timely presentation at facilities where they can conduct more diagnostic investigations to identify these cases. And also, because early warning signs of childhood cancer usually mimics other conditions, other childhood conditions, it usually leads to misdiagnosis and delay referrals to the treatment centers for comprehensive management. We were fortunate that the National Health Insurance covered 4 childhood cancers under the NHI, but still they are not able to cover all the cost, and it is even not very adequate, and people have to still pay out of pocket, which is still a financial problem for and one of the challenges is that most of the facilities, even the major treatment centers, do not have adequate equipment. Specialized diagnostic equipments are virtually inadequate, and we do not also have adequate trained personnel to be able to handle this, like hematologists. We don't have adequate numbers of hematologists. And then we don't also have adequate numbers of pathologists and other oncologists. And this leads to the misdiagnosis and then even challenges with timely diagnosis. And then the stigma, the social cultural factors, And then the alternate beliefs, where most of the people, when they see some of these early warning signs and symptoms, the first place of call they go is to their spiritual leaders, the herbalists and the spiritualists. And then the prayer comes, and then they delay there. And when they are not able to do it, then they come to the conventional medical care, where by the time they get there, it's already late, and that results into poor prognosis and then the poor quality of life. So early diagnosis really matters a lot, and it is one of the most important factor for successful treatment and long-term survival. And then diagnosing childhood cancer early often allows for less aggressive treatment, because chemotherapy, radiotherapy, and the surgeries at times can be so invasive. But once they come early, the chemotherapy, the drugs they give will not be so much. But when they come at an advanced age, these children have to be subjected to a very, very aggressive treatment regimen to be able to turn things around. And at times, most of them are managed on palliative. So early diagnosis and treatment can be more cost effective in the long run when they come early, preventing advanced stage complications. And then the survivors to diagnose early have a better chance of living what their full life and healthier life. We have a lot of them who are contributing significantly to economic and social development in their communities. And these people would have lost them had it not been for the efforts we are making to improve the system. But still, we can still see that it's not adequate. So the golden window is, of course, early warning signs, and then some symptoms, signals. And some of these are persistent unexplained fever, unexplained aches, pains, and limping, swellings, or lumps, especially in the abdomen, neck, and groin, persistent paleness, early bruising or bleeding, unexplained or rapid weight loss, and then changes in vision or the white eye reflex, and then persistent fatigue, mood changes, and headache. All these are some of the early warning signs and symptoms that we need to pick up, and then ensure that they go early to the nearest health facility for further examination, so that in case it is a sign or symptom of childhood cancer, it can be managed early to ensure that they are able to contribute significantly to the society. For wild child cancer, World Child Cancer is a globally, renowned organization that uses systems approach to managing childhood cancer. We support lower and middle income countries in all these endeavors to ensure that we give children their chance to live and to support, contribute their quota to the development of the society. And we have summarized these systems approaches, 4 strategic pillars: early and accurate diagnosis, which I've just spoken about, treatment and care, child well-being and family support, advocacy and communication. And all these is geared towards supporting countries, institutions to be able to provide comprehensive support to children, not only identifying these cases early, but also ensuring that the countries, the hospitals are well equipped for through equipment, provision of drugs, training of healthcare personnel, both pre-service and in-service, so that we can augment the numbers of specialized professionals to provide care. And then child well-being, it is their psychosocial support is very, very important. So we train the health professionals to be able to support these children. In Ghana, very soon we are going to have an MSc program in healthcare play therapy, where these professionals will come out to support children in their treatment, so that they will be able to go through these treatments with less anxiety and cope with their treatment, and also ensuring that the families and even the staff they start providing the care, we support them also to go through some of these things, because seeing most of these bad outcomes all the time can be so draining psychologically for even the healthcare professionals, the doctors and so on. So we need them to be okay, to be able to take care of their children. And of course, advocacy and communication, where we engage governments and other institutions to advocate for support for children with cancer. So early diagnosis is not just a medical issue, it is a societal responsibility, and it is the right of the child to receive care. So just as a child in the US has the right to quality care, those in deprived, low resource settings like Ghana and other countries also have a right to live and to receive quality care. A future where every child in Ghana or in Africa with cancer is diagnosed early and receives timely, effective care. With concerted effort, collaboration, and commitment, this vision is what achievable. We need all hands on deck to ensure that the child deprived somewhere also has quality care, just like any of us in the globe. Thank you very much for listening.
Amazing. Thank you so much, Ayere and Adri. These presentations really clearly outline the context in your countries and the challenges to early and accurate diagnosis of cancers. It's brilliant to see CHOC implementing such a multifaceted approach to awareness raising and training of healthcare professionals in the early warning signs. And it's brilliant just to see how much our organizations are aligned on so many different approaches, including using, the Cillian approach, the EWSS, and focusing on capacity building. So we can get started with the discussion. I was wondering if you could both tell us a little bit more about the current awareness and understanding of childhood cancers in both your countries and in South Africa.
Okay, so thank you very much, Ayere, for your presentation, and I couldn't salute you more, because I think the challenges in Ghana and in Africa is also very prevalent in South Africa. South Africa, we are privileged that our children, most of the children under 5 years, they are, when they are on treatment, the government will pay for it. But I think our biggest problem at the moment is the lack of awareness about childhood cancer, and the fact that people, healthcare professionals, don't know the early warning signs of childhood cancer. For example, I'm just going to quickly go through this. Childhood cancer is a rare disease, but in the basic and post-basic training of the nurses, there's nothing about childhood cancer to prepare them for this. Also, continuous professional development helps professionals to stay competent, updated, and effective in their professions. But in South Africa, this system of CPD accreditation for nurses is also non-existing. When I asked, for example, the Nursing Education Authority in South Africa if we could please add the childhood cancer to the curriculum, there was a clear no, because they say they are taking away content from the curriculum. They cannot add any. So although we've been training healthcare professionals, healthcare workers, and traditional health practitioners on the early warning signs of childhood cancer, we definitely have not reached the numbers that we hope to reach. So our target for 2026 is to start to look at a little bit the higher level than the nurses on the primary healthcare level. And this is our district hospital doctors, because we find a lot of times that is where the stumbling block is, or where the children get to the district hospital, because we have a triage of referral. So from the clinic, they go to the district hospital, but then it's stopped. And our last effort to see how we can improve on the understanding of the early warning signs is the IMCI manual. So the IMCI manual is the Integrated Management of Childhood Illnesses. And that was developed by the WHO and UNICEF. And its intent is very clear and very focused on improving child health especially in low and middle income settings, by guiding healthcare workers to holistic and integrated care. But sadly, there's nothing about childhood cancer in this manual. So CHOC then, in collaboration with the Gauteng Department of Health, the IMCI specialist, and two of our technical advisors, Prof. Pool and Prof. Naidu, we have developed an addendum to the IMCI manual. We've been rolling this out countrywide to train nurses on the use of the IMCI manual. So our hope is that nurses will be able to ask the right questions, look and feel for signs and symptoms, and in doing so, we need them to have a high index of suspicion and then know where to get help. So this is a basic overview of where we stand with understanding childhood cancer in South Africa at this stage.
Brilliant. Thank you so much, Adri. I'm going to hand over now to Ayere for his response as well, Ayere.
Yeah, thank you very much. So in Ghana, we started rolling out the early warning signs and symptoms around 2018, 2019, and we kept improving it. And in 2020, we started developing a tool for early warning signs for retinoblastoma, since that one is a little bit unique, and that was rolled out in the OT and the Volta regions, and then the Eastern region, and then later with support from AMCC, we further developed more materials and rolled it out in the current three northern regions, that's Northern, Savannah, and Northeast. And this was implemented over a 2-year period, which also showed a lot of improvement. So our approach has been public education on early warning signs and symptoms, using the media, using social media, using the radio and television. We also developed jingles alongside, which were played in radio stations. So we have been doing this over the period, and we have also targeted health professionals with a different model, which we roll out. We've actually trained across all the 16 regions of Ghana. Initially, it was 10 regions. We had trained all. When they divided, we rolled out again in the new regions. So we have covered the whole country, including the three northern regions that we deployed the early warning signs in retinoblastoma. So an extensive education has been done for health professionals, including primary healthcare workers. So this has been done, and this has been the approach. And then usually to test knowledge retention, we do the pre-test and post-test, just to be sure the training is well delivered. And we also did an independent evaluation of the strategy. It was a 1-day training. So after the evaluation, it was recommended that it be rolled out as a 2-day program. So currently it's a 2-day program approach that we do for healthcare professionals. And then, of course, we take advantage of international celebrations like the International Childhood Cancer Day, 15 February. So we do an extensive public education, awareness, and training of health professionals on that day. And then the Childhood Cancer Awareness Month, we take advantage to also heighten advocacy on early warning signs and symptoms. So these are the ways that we deploy the program. But what South Africa did is something that has been also tried in Ghana. And then we have approached WHO and UNICEF on integrating early warning signs on the IMCI models. And we have also approached Ghana Health Service to integrate it into the maternal and child health record booklet. because that's also another important educational material for parents. And we have been promised that the next review of the maternal and child health record book will be consulted to integrate some of the early warning signs and symptoms into that book, so that health workers and then families can get some information to arm themselves. So this has been the approach that we have been using in Ghana over the period.
Brilliant. Thank you so much, Ayere. Yeah, it's brilliant to see the kind of same approaches used across organizations, and really highlights the importance of advocacy.
Yeah, look, just before you come, I just want to add an important element. Ghana, what we have done to ensure sustainability in this approach is using the government system to roll out the programs, other than doing it independently as an organization. So these materials have been given to the to Ghana Health Service to deploy, so that they can help roll out the program. So when you go to the health promotion division, these materials are in their repository, which they deploy. And they also have personnel throughout the levels of the health system, and which they use these programs as educational materials. When you go to most of the health facilities, the materials are pasted there, which they use for education, either during home visit, community meetings, debates, and so on. So we are strengthening our collaboration with them to ensure that they help us get some feedback on the use of these materials. So that's the next thing we are doing. And before we successfully did this, we signed an MOU with Ghana Health Service. And we are moving further to sign an MOU with the Ministry of Health, so that we can have an overarching involvement with the state system, because the Ghana Health Service is one of the agencies of the Ministry of Health, and the Ministry of Health has other agencies like the Christian Health Association of Ghana and the Islamic Health Service, and so on. So this is our approach to ensure that there is sustainability in the approach on early warning signs and symptoms, and for proper integration into the universal health coverage.
Thank you, Ayere. Yeah, it's so important to work with the local health system, ministries of health, and ensure that there's collaboration on the approach, especially when delivering early warning signs, raising awareness. And great to see the importance of ICCD and CCAM as being key advocacy points for us, both of our organizations and in the childhood cancer space. Yeah, so awareness raising, really important. So what are some of the kind of most common myths or misconceptions you've encountered about childhood cancer, and where do you think they come from?
So I just want to say I can't agree with you more on the participation and the collaboration with government. We also do MOUs, and we do nothing without taking the hand of government. But when it comes to myths and misconceptions, so we know a myth is a traditional story or belief that's not based on facts or evidence, where a belief can be very personal. So when we start to talk about debunking the myths, we need to take in consideration this very strong belief that can be personal, cultural, religious, or social, because that's how people think, how they feel, and how they behave. So we know that myths and beliefs lead to stigma. And the only way to debunk a myth is to give people the correct information. For example, we know that cancer, the myth is cancer is a white man's disease. So the way how you're going to explain it to people is to say, but cancer affects all races, gender, and age. And that we say, for example, but CHOC's beneficiaries is 80% Black, 2% white, 1% Indian, 10% colored. And this follows the demographics of our country. So once they hear the facts, they understand the myths better. Another myth is, for example, cancer is a cure. Sorry, is a curse. So we say no, it's when cancer got a wrong message, and when it starts, the cell starts to grow out of control, it's not stopped, the child will die. And there's nothing that the parent did or did not do that caused the cancer. But for many years, when we spoke about or referred to the diversity in the African culture or tradition, we would speak, for example, about the mother who didn't do the cleansing ceremony by slaughtering a cow when the child was born, and now the child is cursed with cancer. But we realized that if we want to break down the barriers, we need to refer to the stigma in the Jewish, the Afrikaans, the Muslim, the Christian, to all the communities. We cannot only speak to one community. We need to break down the barriers, not only in one ethnic or religious group, but for all the people in South Africa. So we had to change a bit of the language, how we speak, and what we refer to when we speak about myths and beliefs.
Yeah, so Ghana is not different. It's very similar. In most of the communities, when a child has a sign or symptom of childhood cancer, there are instances where children are born already with cancer. They think these children are spirit children. In some of the communities, they just go and dump these children in the forest. They believe that spirits are in the forest, so they just dump them there, that they should go and join their spirits. So, and these children lay there and are eaten up by wild animals and so on. And and because they think these children are cursed, so these children are not even named. And some of them even think that these children, I mean, children don't get cancer. It's adults that get cancer. There are so many myths and misconceptions around childhood cancer. And and what usually happens is that they send these children to prayer camps for the pastors, the spiritualists to pray over them. And then at times the children are denied even food. You understand? And they ask them to, you can imagine asking a child of 5 years to fast because they think that the cancer was caused by a spiritual hand or something, or they think that some families are hunting them or after them. So there are so many myths around and misconceptions around childhood cancer, and that is why the first point of call is usually the spiritualists. They go to the prayer camps, they go to their churches, they go to their pastor or their imam to do a whole lot of things, and that delays the presentation to the nearest health facility for management. And that accounts for the poor outcomes on the management of childhood cancers in lower and middle income countries like Ghana. So the myths and misconceptions are very same. So what South Africa did in engaging these people to orient them is the best. We have also started a similar approach in Ghana where we are approaching the spiritualists, the herbalists, the traditional leaders, and then the Muslim leaders, and so on, to orient them on childhood cancer. Just that it demands a lot of engagement. So funding now, as we all know, is a problem, but that is a very important strategy that needs to be taken to engage them and orient them very well and rope them into the cycle. But if they are seen as people who are doing bad things and we condemn them, this problem will continue to fester. So we have to just embrace them, orient them so that they can help in the referral, so that we can have timely referral. And once they come early, the outcomes will improve. Thank you.
Thank you, Ira. It's really interesting to see so many similar approaches being developed across both Ghana and South Africa. And it really shows kind of why targeted education programs and awareness raising is really fundamental to improving knowledge and removing those stigmas. Um, Another area is language as well. And I'm just wondering, how does language contribute to stigma and barriers in both Ghana and South Africa?
So in South Africa, we have 12 official languages. And within the languages, there are dialects. For example, the isiZulu spoken in KZN may sound completely different from the isiZulu speaking in Gauteng. So in practice, most South African languages have a word for cancer today, though some are borrowed rather than originated within the language itself. I'll just give you quick examples. For example, in Zulu, we have a word umdlavuza, and then in Xhosa, umhlaza. And both of those describe tumors and growths. Whereas, for example, in Afrikaans, we have the word kanker. And then in Sotho is kankera. And then you talk about kansera in Tswana. So all of these words are borrowed from Dutch or English or a descriptive variant. But there was a very interesting paper that was published in 2024 by Hannah Simba et al. It's addressing the cancer care terminologies in African languages. So barriers in cancer community can very much contribute to a stigma, disempowerment, the impact both on the patient and on the healthcare workers. Because it's not only about the words, it's it's about the translation of concepts into the medical terms. And for example, in some languages, the word cancer is negatively referred to or described as an ulcer, growing that does not heal, or a destroyer, where a tumor is referred to a growth on the skin believed to be a sign that the child has been bewitched. When we look at radiotherapy, it yielded a high percentage of negative connotations. And I'm sure most of you have heard about the prevailing theme of describing the treatment as being burned, electricity, fire, or heat. And I mean, if I'm a child, I will run away. I'll be so scared. So the way in which we communicate or translate the oncology terms to patients and families can really lead to fear, health disparities, barriers to care, and it's especially when a healthcare professional needs to use a translator, because that might lead to miscommunication, and it might lead to treatment abandonment and fear. So there's a huge need for culturally sensitive cancer terminology and to improve the childhood cancer awareness and the correct knowledge through using the correct language in communicating to people in Africa. In South Africa, with all our different languages, it's quite a challenge, and I'm sure Ayiri feels the same in Ghana.
Yes, so language indeed is an issue, but what we did was to integrate local language during the training, even for health professionals, because they need to know the terminologies in their local language. And just like Ghana too, we have several languages across the regions. So, but integrating this into the training was very innovative, because most of the health professionals did not know the terminology for cancer and then the signs and symptoms. So this really helped, and most of them were happy that we had done that after a period of time, because they could now communicate better. The communication improved on cancer, and then the signs and symptoms of childhood cancer. So it really plays a very important role in demystifying most of the myths and misconceptions around childhood cancer, and in their proper communication with parents and children, because once even in the whole communication about the treatment, we emphasize the importance of the local language. They understood this, that it's very important in even communicating the treatment journey to the children and the parents, and letting them understand the role it plays in respect, in respectful care for family. So that is very, very important. But when they come and then they are communicating in only English, it creates a lot of barrier between the parents, the child, and the medical team. So language is really an important factor in the whole process, and I mean, we cannot underestimate the role that it plays.
Thank you, Ira. It's so important, isn't it? And I've experienced use of fatalistic language like uncurable or death sentence, things like that. And it's really important to kind of raise awareness and focus on kind of education campaigns to increase that knowledge, particularly around childhood cancer. Um, we're going to move over now and have a do the Q&A on the chat. The first question I have seen is, World Child Cancer has been working in Ghana for 15 years now. Are you able to say which inputs have made significant positive changes so far? So this one's for you, Ira.
Emma, thank you very much for that question. And that is really very difficult to tell which particular. I think is a cumulative approach. And what we have seen in Ghana is that generally, in summary, the approach is effective, because when we started, the total number of confirmed cases around 2017, 2018 was about a maximum of 300 cases, confirmed cases. And then the mortality rate was very high. And then, so when we started, we started with the health systems approach, providing equipment like the safety cabinet, the BP apparatus, the monitors, and so on. And then we started training the nurses, the doctors, the pharmacists, and then we also had a training visit where people like Emma and others were coming, because we wanted to train with the advanced health system, with the Ghana health system, so that they can learn, so that the advanced health professionals in advanced countries can mentor the health professionals in Ghana. So when we did that, and then we also started the pediatric oncology training at the Ghana College of Physicians and Surgeons to locally produce in the local context. And then the Ghana College of Nurses and Midwives, we started training nurses. And then we also did the awareness creation and all that. So, and then we were providing cost of treatment for families, cost of transportation, and then so all this together with the nutrition support, we did an evaluation of our data. We collected data, and then for the first time, we were able to estimate event-free survival and overall survival rate. Then we realized that the survival, that using the data that we collected from the three major treatment centers, no, the two, Kolebu and Konfanochi, then we saw about 56% survival rate, which is very high in respect of what we have been seeing in low and middle income countries, where the survival just range between 10 to 20%. So you see, Ghana was about 56. That was very high. And this is from the data that we collected from Kolebu and Konfanochi. So definitely, I would say the cumulative effect of the support that we provided enabled us to see this. But I can't say today that the survival rate remains the same. We need to collect the data and then re-estimate to confirm whether what we did in 2020 was really what it is. So and obviously we are not the only player in the system. The government is playing their role. Other angel like Lifeline and others are also doing their bit. But at least World Child Cancer is the biggest intervener in this sector. So we can say that all of us did well in pushing these forward.
Thanks, Ayeri. Yeah, I 100% agree with you on data-driven programming. I think that's a really strong area of the work that we do. In the interest of time, I'm just going to look at the Q&A. We have one question from Kareem. We keep inviting people to report earlier to the nearest health facility, but are health systems welcoming people well in the way that can be encouraged to report earlier in the case of their childhood cancer? How to improve this, knowing that the childhood cancer is still a rare disease and can mimic other ones? Not sure who wants to take that question.
Yeah, it's from Karim. I know. Yeah, so Karim, thank you very much for that. Yeah, so we need to continue. We cannot be discouraged by what we are seeing, and that is why I stated that even though we are targeting families on the early warning signs and symptoms to ensure that there is early presentation, and then we also target the health professionals on communication, on their psychosocial well-being, because there is burnout, there's a negative effect on the poor outcomes, because some of these health professionals are so attached to these children, and then only to realize that these children are going to die, they are on palliation, and then you come in the morning and then you want to come and see child A, and then you get there and then the child passes. You understand? And some of these children are even telling you that they want to be cured and they want to become the president of Ghana. They want to become the minister for health. They want to become a big doctor like them, and so on, only to come and discharge. So the devastating effect on healthcare professionals, you cannot even imagine. So we have clinical psychologists that are taking them through to make sure that they are able to go through some of these stresses to remain calm. And then we also take them through communication, how to communicate effectively, and even communicating the bad news. So there's a lot of capacity building that we are doing to improve on this. And then World Child Cancer is also advocating for the government to provide support besides what we have been doing to the major treatment centers to make sure they are equipped to be able to take most of these cases. But obviously, all that we are doing, the numbers are increasing. We are seeing increasing numbers as are demonstrated. The numbers are increasing. And so and this calls for more help. This calls for more investment into the area so that when they come, we are able to take care of them and then improve their survival, improve their quality of life. And not only, we know we can't cure all of them, but those that cannot be cured, of course, will be able to provide quality palliative care for them to die peacefully and not in pain. So there's a lot that we all have to do together for these children. They also have a right. It's their human right. It's part of the human rights. So we have to look at it as their legal right to quality treatment.
Thanks, Ayeri. Adri, I can see you nodding your head and agreeing with some of Ayeri's points. I wonder if you want to add anything for the final.
I just want to say, you touch on so many points here, but I think one of the very important points is the care of the carer. And that is the person that we omit and that we don't see. And the care of the carer is the doctors. It is the it's the nurses, it's the parent who's caring for the child, it's the sibling who sometimes is the head of the household. So I think, and when it comes to end of life, I just say that, yes, it is very hard. But what we always say to our traditional healers, if a child then prefers to die within the cultural context, the only thing that we ask is the child may not die in pain. Please, that's all we ask.
Thank you, Adri. I think that will be our last question for today's session. I just wanted to say thank you, everyone, for joining us today for this important session for London Global Cancer Week. It's been a privilege to host this alongside our partners at CHOC. And thank you to our guest speakers for joining us and for such an insightful discussion today. Be sure to check out our socials and websites on behalf of
Look,
yes, I hear it.
forgive me. Before there was a question in the chat this thing. I just want to, somebody was asking about survivors. So I just wanted to say that we have scholarships for survivors, either for continuing education or to learn a trade in Ghana. So survivors are also being taken care of. Thank you very much.
Thank you both, and thank you to everyone that was able to join us today. Thank you, everyone. It's been a great session, and we'll see you all soon, hopefully. Thank you.
Thank you. Thank you very much. Go well. Thank you.
Thank you. Bye-bye.